Good morning, everyone. How are y'all doing? Yes, do you mind letting in my other account too and making that one
recording in progress.
Okay. All right, we're here. Thank you for joining. Steph isn't able to be with us today, but and I haven't been on Wednesday VMR for a long time, so it's really nice to be back, and I'm excited to chat with you all and hear about a case and learn something together. What's new? What have I missed the last 2 weeks? Any cases that are particularly memorable to y'all? I did miss you, Noah, that's right. Ooh. IMG ERAS, that's big. There's a T-cell leukemia case. Oh my gosh, Kiara. That's amazing.
Yeah, sadly I wasn't
more.
able
That's
to
incredible.
There, but yeah, it's a lot.
I don't know how others feel, but I feel like even when you hear about a case, discuss a case, like some you just remember forever, some fade. It would be so amazing to just kind of go back and revisit some of those cases. I can't even like imagine what that compendium of looks like. Yeah. Austin, hey, glad you were able to join. So does anyone by chance have case number 1001 to complete Scheherazad's benchmark? That's the number of tails, right? In Arabian Nights? No? Okay. Austin, anyone? I don't have any. Interesting cases are good. Cold cases are good. If anybody's currently seeing patients and saw somebody without necessarily a final diagnosis or resolution, I think we can still have a good discussion and learn together. Austin, it looks like we may benefit from that, and also curious if anybody wants to take a more active role and be a discussant, or if everybody wants to kind of have at it together, we can do that too. Yaz, you're up for discussing?
Of course, but what about someone who hasn't?
Or did I misunderstand the chat?
I'm good with somebody who hasn't discussed in a while. I believe that I just discussed with Shema last week. So if anybody else is up to the challenge.
And who's scribing today?
It's Noah.
Noah. Okay, awesome. Thank you, Noah. Okay, awesome. Ricardo.
Ricardo's an IMG. Yeah, totally.
Ricardo, have we met?
Hi, everyone.
Where in the world are you, Ricardo? I'm sorry that I don't know.
Hi, yeah, right now I'm in the airport, like in Houston. So.
Oh, cool.
Yeah. Yeah, so hopefully I will, my connection is at 2 p.m. So hopefully I will be able to discuss. So it's my first time. So sorry if I don't do it like the best way possible.
Don't be sorry. That's awesome. Thanks for engaging. And what do you do in your non?
Atención con
non-
los pasajeros Hernández, Enciso y Ramírez Hernández.
Yeah, so I'll be at Texas Tech in Lubbock, like doing an observership, 2 months observership. So yeah, the flight to Lubbock is like today at 2 p.m., 2:45.
Awesome. Congrats.
Thank you.
Congrats. All right. Let's so we decided Austin was gonna share a case. Thank you, Noah, for showing us the visuals, and we can start whenever y'all are ready.
All right, sweet. So this case is of a 50-year-old woman who presented to the emergency room with dysphagia.
And Austin, I thank you for getting us started. I actually there's a lot of different ways to do this, of course, but I kind of feel like Aaron Berkowitzing it a little bit. So could we pause at the chief
Sure.
concern here, and Ricardo and I can just talk as much as we can about dysphagia, and then see how the details of the history fit in. So what do we know about dysphagia? How do we think about it, Ricardo?
Okay, thank you, Zaven. So yeah, so like the first approach, like I think of dysphagia is like basically like 2 different points. So
Atención, por favor.
that time course, so if it's acute or chronic, and also, for example, because if it's acute, it may be like something like a foreign object, especially, or maybe like some sort of complication from a surgery that was recently done, while also, for example, like CPRE, I don't know if that's how do you say in English, like retrograde endoscopy,
Yeah, ERCP.
cholangiography, yeah. Yeah, so like it can be like from a recent procedure. Well, if it's chronic, like it will be like a totally different approach. So more like tumors, or also like some type of connective tissue diseases, or like that may be causing like some fibrosis. And let me know when you want me like to stop.
Keep going. Yeah, you're doing great.
Yeah, so I was thinking on that, like especially the time course that is going like to basically like make us like think on different things. It's not the same as something acute as something chronic. And as well, also like it's very like as I said, like has this patient had any recent procedure, any recent surgery, any, and also like if does he have like risk factors for neoplasia, or also we have like to difference, for example, if it is like something structural, like is it like something anatomic, like maybe some compressions or some tumor, or something that more functional. So from what I remember, like when you have dysphagia that starts like from liquids and progresses to solids, that indicates something that is like more anatomical, while if it's only liquids and like not the same sort of progression, it's like more functional, if I'm not wrong.
Outstanding. I think most people, I'll kind of show how I think about dysphagia generally. And acute or chronic isn't typically part of that, but it totally should be. And I think your starting point shows just how critical time course is for any presentation, right? So for example, I saw on Twitter the other day a video of a Komodo dragon, this like massive lizard, swallowing a deer whole without chewing. It just swallowed this deer, this massive animal, right? And if that Komodo dragon came to the ED and says, I can't swallow ever since I swallowed that deer, right? okay, I guess maybe too far of an analogy. If I ate a steak right now and didn't chew and suddenly after that couldn't swallow and went to the ED, the whole like liquid, solid, right? Like all of those oropharyngeal versus like that would go out the window. That hyperacute, like brand new 0 to 60 dysphagia would have a completely different kind of mindset and differential, right? Or if I had dysphagia immediately after having an endoscopic procedure or something like that, right? That you also alluded to. So I thought that's phenomenal, and I'm going to incorporate that. I think of dysphagia as far as where the problem is happening first. So there's oropharyngeal dysphagia, which is usually a neurologic problem of processing and moving back the bolus of food from the mouth into the esophagus, versus esophageal, which is once it gets past the oropharynx, then it's getting stuck, right? There's difficulty passing the food from there. And that's where kind of your approach of, does it seem to be a mechanical obstruction, which is often characterized by sort of progressive dysphagia that is mostly to solids, but then when it gets really bad, it's to liquids also, versus if it's a dysmotility problem, sort of a neurologic problem of the esophagus, then no matter what you're trying to pass, you may have trouble, including liquids sort of earlier on. And then you kind of went on to mention some of the specific and common diagnoses like malignancy, and how they typically present. I think we're already kind of starting to keep the age in mind when it comes to that, right? And we'll look for some of the risk factors for the particular conditions. I think one nuance I want to mention in the breakdown of all of this is that a lot of times chronic processes can present acutely, right? And then that differentiation of liquid solid progression, all of that can isn't perfect, right? So for example, if you have a slowly growing mass and you're kind of adapting one day, you might not chew a steak well enough and present much more acutely, right? Or a common condition in younger people like eosinophilic esophagitis, even though it's not an acute process, it's something that kind of goes on for a while. Very often it actually presents with a very short time course of symptomatology. So as we hear the story without necessarily...
Yes, totally agree. Thank you.
As we hear the story, we'll try to kind of overlap that with the framework and then ask some follow-up questions if we need. Austin, thank you.
All right, very good. So we'll just give you some of the HPI and then fill out the southwest corner. But yeah, basically she presented acutely to the ER, as I mentioned, after eating some rice, and she felt like there were some beans in the rice that got stuck in her throat. So she actually underwent an urgent EGD in the ER, and it revealed a food impaction with stenosis in the proximal esophagus. And then after we kind of got the acute event taken care of, we were talking with her more, and it was discovered she had really more of like 9 months of progressive dysphagia, which had led to about 20 pounds of weight loss, as well as some fatigue. So I'm just going to let them catch up a little bit. And then as far as the review of systems goes, there was no choking when she was swallowing. There's no coughing when she was swallowing. There was no regurgitation of undigested food. There was no B symptoms, no obvious blood or coffee ground emesis that she was having, and no other abdominal symptoms or any other positive things on her review systems. So as far as her medical history, she actually had a history of GERD that was longstanding and had multiple prior dilations for peptic strictures, but it had been years since she had had one previously. Family history-wise, she did have a mother with gastric cancer, kind of older in life. She wasn't taking any medications, and then she worked as a teacher She ate sort of a normal or the SAD diet, aka the standard American diet, and had no alcohol, tobacco, or substance use. And I can stop there, or I can move on to the vitals and exam. What would you guys like?
I think let's pause there, and Ricardo, let's talk about, like, we've made some progress. Clearly, there's a lot of information. Yeah, where are we? How would you represent this problem now, and how has the differential narrowed, if at all?
Yes, thank you, Zaven. Yeah, so basically, I wanted like to ask some questions, like the prior dilations are in the esophagus, like, or because I heard that there were like peptic ulcers. So
You said yes. Mhm.
oh, okay, peptic strictures. Oh, okay, and they are in the esophagus. Okay, perfect. Yeah, so yeah, so since this patient, like she has like a long duration of these symptoms, and she has had weight loss, even though she doesn't have B symptoms, like she doesn't say she has fever, night sweats. I think like also because of the family history, like we have to rule out definitely cancer. Like I think that's something like we have to rule out for sure. And also I was thinking also like maybe like it comes to mind like maybe that to ask about sexual history. I was thinking like maybe HIV, like maybe this like the neoplasia could be related like to some immunosuppression. And I was also thinking like it could be related maybe to HIV or BPH, though I think like neoplasias like with this grade of obstruction, like I don't think like yeah, I don't think like they will be caused by BPH. And also I would like to have also in mind like some other alternative diagnosis possible, like maybe some sort like of compression, maybe like from a lymphadenopathy that may be caused by a lymphoma, I thought. So yeah, those were like some things some ideas that came to my mind.
I love that. That's amazing. So you're thinking of kind of mechanisms of compression of the lumen, and you went all the way from inside out, right? Inside the esophagus, you can have cancer, and we'll sort of expand that in a second. Infection, and a lot of times you're absolutely right. Infectious esophagitis occurs in the setting of an abnormal immune system, right? Whether that's Candida, whether that's HSV, whether that's CMV, all of those tend to happen in patients with cellular immune deficiencies, right? Like HIV, like chronic steroids, things like that. Often they present with pain in addition to dysphagia. Okay, cancers. What kind of esophageal cancers do we have? Anybody want to throw out the two kind of major types? Okay, squamous cell, thank you, Marino, and adeno. Good. And those are both like of the luminal like mucosa, right? So squamous cell happens more in people who smoke and drink. Adenocarcinoma happens more in people with longstanding reflux, right? That's what like Barrett's esophagus is a precursor to. Adeno tends to be more in the distal esophagus. Squamous cell tends to be more proximal, but again, those aren't perfect, right? Those are just associations. This seems to be a proximal problem. And then you can have like a benign cause, right? Like strictures, fibrosis from the chronic inflammation, from the chronic injury of reflux. That's what the patient has had before. You know, it's very possible that that's what the patient has again. It's also possible that this problem has been going on for a while, and maybe it's been missed. I forgot exactly when all of the prior scopes and dilations were. Marino, I see you're mentioning esophageal webs is another mechanism of sort of inside the esophagus kind of luminal stenosis. But I love, Ricardo, that you didn't forget the possibility of extrinsic compression, which is good to think about anytime you're thinking of any tube that is compressed, right? Whether that's the bile duct, an artery, a trachea, you can have kind of outside in. And you mentioned lymphoma, and any other kind of mediastinal mass, right, can press from outside in and cause stenosis. So that's all excellent. One of the intraluminal kind of causes are more common, which is why, endoscopically, oftentimes you're able to see the problem and certainly biopsy the problem. But if the mucosa there it looked intact and just sort of normal, not ulcerated, not inflamed, not strictured, and there wasn't kind of a mucosally based lesion or webs or something like that, then some endoscopists would be able to do like intraluminal ultrasound and actually visualize potential masses outside. But short of that, cross-sectional imaging of the neck and thorax would reveal a mass if it was big enough to be causing this kind of symptomatology this bad. So I think those are the possibilities. And honestly, the weight loss doesn't move the needle too much towards one or the other, because we're talking about a structure that's affected with which we maintain our weight. That's how we eat, right? So whether it's a benign cause or a malignant cause, if it's bad enough to be causing decreased oral intake, hopefully the weight loss doesn't necessarily mean that this is cancer, right? Any other comments, Ricardo or anyone else, before we see how our patient looks?
Yes, absolutely. Thank you. I think like what you say totally makes sense. We cannot like rule out that it could be maybe like some benign cause. And yeah, because like the tube is basically obstructed, so it doesn't necessarily need to be something malignant.
Thank you. And I think just for completeness, someone else had mentioned this already, but some collagen vascular kind of infiltrative inflammatory causes, including scleroderma, I think is worth just mentioning too when it comes to esophageal dysphagia and stenosis. Austin, move us forward, please.
All right. Yeah, great. Very nice discussion. So the vitals, to summarize, to say all of her vital signs were normal. And then on her physical exam, she had no lymphadenopathy. There was no organomegaly. Her conjunctiva was normal. Her oropharynx looked clear. The only thing that we really saw was that her tongue was very smooth and shiny and without any sort of the normal red papilla that you would usually see on her exam. So we can stop there, or I can also give you the initial rounds of labs.
Whatever you think, but my sense is that it'll be more efficient to get the labs too.
All right, great. So yeah, this will be a little bit heavy. So I apologize to whoever's scribing. So as far as the CBC goes, the white blood cell count was 2.7 with a normal differential. The hemoglobin was 8.3 with a MCV of 117. And the platelets were 88. The reticulocyte count was normal. The haptoglobin was low. The LDH was 2,600. The total bilirubin was 1. And the smear showed a few schistocytes, dacrocytes, and smudge cells. And then her chemistries were normal. I think we can stop there for now.
Amazing, Ricardo. I enlisted the wisdom of the group to just help us remember, like, if we see a tongue that just kind of stands out as smooth and glossy, what do we think about that? But we definitely, that was a lot. Austin delivered on his promise. So let's dissect some of these labs a little bit.
Yeah, like what you ask me is like, what do I think about the tongue, right?
Oh, no, well, you can certainly feel free to comment. I asked the chat to comment on the tongue, but just because
Pardon.
there's so much labs to kind of talk about, so maybe we can focus on the labs and then see if the tongue differential fits with anything that comes up in the labs.
Yeah, that sounds good. Perfect.
So what do you think about this pancytopenia, the LDH, schistocytes, smudge cells? Any thoughts on any of that, Ricardo?
Yeah, so this is like a very interesting case because like yeah, I want to like to ask another thing. Like you said the differential was normal, so neutrophils were good, right, Austin? Okay.
I think the neutrophil count was, slightly low just given the leukopenia, but the percentages were generally normal. There wasn't eosinophilia predominant or anything.
And how was like the count, like the actual number of neutrophils, please?
I don't recall, but let's just say it was like 1,800.
Okay. Yeah, so I was thinking like this is like such an interesting case because like there are like so many different findings, like abnormal findings in the lab. So we have like leukopenia, and we also have like anemia that is macrocytic and thrombocytopenia, and like the elevated LDH and the low haptoglobin indicate like there's possibly like some hemolytic process going on, and like the schistocytes, from what I remember, they indicate that there may be like some sort of mechanical disruption on the vessels that may be causing like the hemolysis, or it may be caused by like other like causes that like in a woman of this age, like it will, I'm not really sure if maybe yeah, this doesn't seem like a PTT. I don't know if that's like the purpura, like the So, and the dacrocytes and the smudge cells, like the smudge cells are in CLL, but this doesn't like pardon, like the airport is
No worries. We can still hear you actually.
okay. Yeah, so the smudge cells indicate like CLL typically, from what I remember, but like this case, like the leukocytes, yeah, it could be. I remember like the CLL, like the most important prognostic factor from what I remember is thrombocytopenia, but I'm not sure if this is CLL. It could be a possibility. Typically, like the leukocytes are very elevated, but I'm not really sure if they could be low. So yeah, I think like we cannot rule out CLL. And yeah, the dacrocytes, I honestly don't remember. Like what do they cause them? Like those are the teardrops, if I'm not wrong.
Yep.
Yeah. So that's. Do you want anything like to add or like to?
That was beautiful. I mean, I'll start with kind of what I think everyone, including me, is struggling with is whenever we hear something that we associate very closely with a given disease. In fact, only one disease, right? Like smudge cells equal CLL, right? But then otherwise it doesn't really fit. You're absolutely right. You're much more likely with CLL to just randomly discover an asymptomatic white count of 80. Right, than to have CLL with a white count of 2.7. Like so I think this probably isn't CLL. And then the question is, well, what's up with the smudge cells? And the truth is, for a lot of those things that we have very tight associations with, they're actually often a lot less specific than the books might suggest. And basically what smudge cells are is basically more friable, and assuming that the smear was processed in an appropriate way, right? Like you can create smudge cells from normal blood just by traumatizing it enough. But it essentially suggests kind of a rupture of a high percentage of white blood cells, which which I don't necessarily have like other causes for. I would be speculating, but I've definitely seen some degree of that just by virtue of kind of specimen processing in patients who don't have CLL. Working backwards, the teardrops, you asked kind of specifically what they might represent. What I know, and I'd love others to kind of chime in a chat, is it's a sign that something's going on in the bone marrow. And so whether that's a primary bone marrow process, and by the way, we're sort of like transitioning towards the differential of pancytopenia as well. If it's a marrow problem, it could be a primary lineage problem, right? Leukemia, myelodysplastic syndrome, myelofibrosis, et cetera. Or it could be infiltration from outside into the bone marrow of either infection, usually atypical infections, TB, fungi, things like that, or malignancy, which usually if it's like a solid malignancy disseminated to the bone marrow, I mean, you have just extremely disseminated disease. But the other sort of mechanism of pancytopenia via bone marrow problem is not having the right tools, the right resources to make the cells. The marrow is fine, but you don't have vitamin B12, for example, or folate to synthesize all those new cells, which, as some people kind of pointed out, the macrocytosis fits with B12 deficiency, for example, but it also, whenever you have a primary bone marrow process, often you have macrocytosis along with that. I think what's shifting us a little bit away from like hypoproliferative processes towards potentially, or rather like towards B12 deficiency specifically, is the hemolysis. I saw someone mention along the way, I think it flashed by that severe B12 deficiency, you can have not only like hypoproduction, but also sort of production of abnormal cells that then sort of die before they're actually make it out into the world as functional cells. And that's where you often have sort of a hemolytic picture with a very high LDH. Some of that hemolysis is intravascular and intramedullary, resulting in the low haptoglobin and schistocytes potentially. And what did people, I totally missed what people said about the smooth tongue. Is there a connection there? Sorry, I can't find it. The only sort of my framework for that is really like, it's essentially a surrogate for inflammation, glossitis, and it can happen in from any actually B vitamin deficiency. You can get it in B12, but you can also get it in a deficiency of other B vitamins, niacin, riboflavin, et cetera. So I think that kind of fits with the hematologic picture too. Of course, we're going to check B12 levels and methylmalonic acid and sort of confirm. But then the question is why, right? Is this all just in the setting of malnutrition and decreased intake, which you can run out of a lot of B12 vitamins pretty quickly, B vitamins pretty quickly. B12 takes, you have slightly longer stores of, but it seems like this has been going on for long enough. The other possibility to consider, though, is that the patient has a malabsorptive process too. Pernicious anemia, probably the most common cause of B12 deficiency. And as an autoimmune disease, there's associations of pernicious anemia, for example, with an atrophic gastritis, with gastric cancer, if not necessarily esophageal cancer. I actually don't know that. Maybe someone can PubMed it for us if there is an association of esophageal with pernicious anemia. But yeah, I think we've sort of like zoomed into this very abnormal CBC, something with the bone marrow, hemolysis, kind of high pretest for B12 deficiency. But whether there's pernicious anemia or whether this is just sort of like decreased oral intake malnutrition, the esophagus is still unexplained, right? And so that's still something that we need more clarity. Talk to the GI doctors. How exactly did things look? Did you biopsy? We need those results in order to form a complete understanding of what's going on with the picture. That's awesome, Rez. Thank you. Appreciate the ID input. Cool. Ricardo, any other reactions, questions, anyone else?
Yes, so I was like reading like the teaching points, and I'm glad like people mentioned effectively, as we said earlier, like sarcoidosis and scleroderma. And if I'm not wrong, I also remember like a disease that may cause like fibrosis, which is IgG4 disease. I know it can cause retroperitoneal fibrosis. I don't remember if also mediastinal fibrosis. I would think so. So maybe also have that in mind, even though it's not that common. And yeah, like definitely connective tissue disease, and also as like they mentioned earlier, like something that could be cardiac, like compressing, like an aneurysm, or yeah, some sort of vessel malformation, like a compression, like causing compression.
Oh, that's a cool pearl. Yeah, we do a transesophageal echocardiogram from inside the esophagus. And the first chamber we see is the left atrium. So yeah, severe left atrial enlargement can cause dysphagia. Thanks for reminding us about that, Ricardo. All right, Austin, what happened?
All right, yeah, no, wonderful discussion and teaching. And so we did get a vitamin B12 level, and it was undetectably low. And the patient had a positive intrinsic factor antibody. So she was diagnosed with pernicious anemia. And this is not where the story ends, though. So she got her vitamin B12 supplementation, and her sort of markers of hemolysis, the microcytosis, the leukopenia, and the thrombocytopenia all improved, but her anemia did not improve. So what would you guys be thinking about now?
Ricardo, what do you think about Dale's idea here? Concurrent iron deficiency. Why and how would that happen? Is it connected to anything else?
Yeah, so like everything improved except the anemia. And did like her like obstructive symptoms improve, right?
No, so her obstructive symptoms did not improve. She was still having the difficulties with dysphagia.
Okay. Yeah, honestly, like nothing comes to my mind like right now. Like maybe if I give me like 5 minutes, and maybe if something comes to my mind right now, I could tell you. But right now, I don't know. Sorry.
Don't be sorry. Nothing to be sorry about. That's in real life, we not only have 5 minutes, but we also have all of our friends, the whole internet, all of the CPS schemas and other resources that we love to use. So yeah, and our friends actually have some amazing ideas, Ricardo. So if we fixed a B12, the anemia didn't get better. I'd be curious what the MCV did, if you had sort of the luxury of more time, some days, some weeks to see where things settle out. But just common things also being common, and related things being related. I think the iron deficiency is very possible here. And we need to kind of test for it. And the way that it would connect with the dysphagia potentially is what people are mentioning as Plummer-Vinson syndrome, which is the combination of esophageal webs with iron deficiency. I've always I feel like I've looked up the pathophysiology of this like a million times. Like, is it the webs that bleed and cause iron deficiency, or is it something about iron deficiency that causes you to form the webs? And I can't remember which of those it is, and or even if it's known. So I'm sure Austin will tell us if that's the case. But yeah, no, B12 deficiency and iron deficiency are very commonly concurrent, actually. When you have a pernicious anemia, you have intrinsic factor antibodies, right, against the parietal cells, which make hydrochloric acid. and that achlorhydria, the decreased acidity in the stomach, actually impairs iron absorption. So the pernicious anemia can cause both B12 and iron deficiency. Other things like Abdulaziz mentioning celiac disease, obviously like pan malnutrition, right? Nutritional deficiencies run together. Almost always when you work up anemia, right? Even if the MCV is high, it's worth checking iron studies along with the B12 folate. And even if the MCV is low, I personally tend to send a B12 too, because again, things run together and the MCV can settle out in a variety of places along the spectrum.
Amazing. Thank you.
Austin, you still there?
Oh yes, sorry, I guess I'm up here. All right. So the initial iron studies that we did, because you guys are right on it, was actually showed a normal ferritin, and it had a transferrin saturation of 70%. So
Is the transferrin saturation, is it like normal or?
Yeah, so 15 to 50% is normal.
Okay, so it's elevated, right?
It's elevated.
Fascinating. Austin, do you have the MCV like after B12 treatment by chance?
Yeah, I think the MCV was something like 85, something like that.
Kind of low normal. Okay.
So I will tell you that the iron studies were done at the time of when the patient initially presented.
Yeah. So Ricardo, normal ferritin, high transferrin saturation. This argues against iron deficiency, right?
For flight number 40.
Yeah, like, honestly, like it gives me mixed signs. I don't like I'm not. So the ferritin is normal. So typically, like I know, like we're gonna definitely rule out malignancy, but like malignancy or something like chronic disease, we would expect it to be elevated. So that kind of stuff, like, makes me think that maybe we are not dealing with malignancy. And also, even though the ferritin is normal, like the fact that the transferrin saturation is elevated, that like makes me feel that maybe like there was like some sort of deficit, and that's why like it was elevated. So yeah, like that's like some of the thoughts I have.
Right on. So iron studies can just be really tricky, right? You alluded to the fact that ferritin is an acute phase reactant, can be elevated from any inflammatory condition. So you can have iron deficiency where your ferritin would be really low, but you're inflamed, so it gets kind of ramped up a little bit by the liver. In those cases, we use the transferrin sat actually, and if there's iron deficiency, usually the transferrin sat is low, and that's where you can still kind of find a fitting picture with iron deficiency, even in the setting of inflammation. If the transferrin sat was 7% as opposed to 70, right, with a quote unquote normal ferritin. But this is high, like this is anti-iron deficiency. And that's where it's good to keep in mind also what can falsely elevate the transferrin SAT2, which is the ratio of the free iron concentration divided by the TIBC or transferrin. And that's basically like, things sort of introduction of free iron into the system, which includes like, if I like my transferrin stat, like this minute might be 20%, within the normal range. And if I eat a big steak or a whole deer and I actually swallow and digest it, right after it might actually be elevated. And that doesn't mean I have hemochromatosis. That just means I just had like an injection of iron into my bloodstream, essentially. Same with like people who just got transfused, right? So if this patient's presenting hemoglobin was 6.7, right? they probably would have gotten a unit of blood in the ED, and if the blood got drawn right after that, it would screw up the iron studies, especially the free iron and the transferrin SAD. I'm wondering now whether intravascular hemolysis, just by kind of leaching out a bunch of hemoglobin and saturating the haptoglobin like it has in this case, can also mess with the free iron assay and thus the transferrin SAD. But I think the practical point here, I would say, is if you have a super high pretest probability for something and you're surprised by a certain lab result, repeat the lab result. Sometimes it's an error. Sometimes over a couple of days, things become more definitive, kind of trend in one way or the other. So that's what I would do, is repeat the iron studies, but also just not like be too married to that idea, right? I think let's not sort of get too into it just because of time, but we should probably also just think about other causes of anemia, and then once again, kind of going back to the esophagus as another unexplained problem. Okay, if there is iron deficiency and if the endoscopy report says these were consistent with Webb's, fine, right? But if we don't have that esophageal support of iron deficiency, we still need to kind of pursue kind of understanding of, do we need a biopsy? Do we need scans, et cetera? Austin, you want to move us forward?
Yes. So, as just as you mentioned, and as Prof. Russell like to say, if there's a trust that you get the first time doesn't make sense, you don't trust it, just repeat it. So that's exactly what we did. So this time around, the ferritin was 11 and the transferrin saturation was 9%. And then to just give you the final aliquot before the diagnosis, so she was still having this dysphagia this entire time. So she ended up having many EGDs, but sort of representative one that she had, again, revealed strictures, or a stricture in the lower esophagus and multiple cervical esophageal webs, and the biopsies were negative for malignancy.
Thank you. All right, what do you all think? Ricardo?
Yeah, so I remember like from the steps, like Plummer-Vinson syndrome. I remember like the mnemotechnic. I don't know if that's the word in English, like mnemotechnic. Like it was dye, so it was dysphagia, iron deficiency, and esophageal webs, I think. Yeah. So yeah, like that's like the diagnosis that comes to mind, like to my mind at least. I don't know, what do you guys think?
I'm with you. Don't have anything else to add. Just excited to hear the resolution from Austin and teaching points from Austin and Noah.
All right, yeah, no, guys, awesome job. And this was a case of a woman I sort of consolidated, but initially like came to my clinic to establish care, like after she went to the hospital for the initial episode. But yeah, she ended up being diagnosed with symptomatic B12 deficiency that presented as what we sometimes call like a pseudo TMA, which is basically how our labs manifested, and then had concurrent iron deficiency anemia with Plummer-Vinson syndrome. And the dysphagia was really multifactorial from like both the peptic strictures, as they're called, so strictures related to uncontrolled GERD, as well as from cervical esophageal webs. And then it was unclear if there was a component of B12 deficiency itself can sometimes cause a sort of neurogenic cause of dysphagia, but that her dysphagia really didn't improve very much with the B12 supplementation. So we really thought it was more anatomical. So yeah, I think this case for me was just a great example of, as the CP solvers has taught us many times, like there are certain conditions that come together. So if you have one vitamin deficiency, you should always be evaluating for more vitamin deficiencies. You see one sexually transmitted infection, you should be looking for other sexually transmitted infections. One electrolyte abnormality, multiple electrolyte abnormalities. But this was a great case that demonstrated that. And then, the I think at this point, we've seen many cases on VMR of different manifestations of B12 deficiency, but I think the classic schema that we learn or illness script that we learn in medical school about macrocytosis and anemia and megaloblastic anemia, is incomplete. And it really has protein manifestations, and B12 itself, in this case, it was really a slam dunk, but the more I've done this and read about it, just all vitamin tests in general really have very poor operating characteristics. So if you really have a suspicion for any vitamin deficiencies whatsoever, there are many, many, many cases documented of normal B12 levels in patients with B12 deficiency. And even the MMA has its caveats as well. So always be thoughtful about how good your tests are when you're interpreting them. And I think those are, my key takeaway points from this case. And, Promise has written a ton, so I'd love to hear about their points as well.
Yeah, I wanted to say something for the teaching points. I wanted to thank everyone because it's my first time discussing Zaven. Thank you very much for the opportunity, and Jazz as well, and all the CPR Solver team for giving me the opportunity to discuss a case with all of you. And in regards to the case, I really liked it because it taught me that even though there may be some findings that may make me think at the beginning of the approach that it was something malignant, or maybe something more of a zebra, I don't know, some immunosuppression. I what it's what they always say in medicine, you always have to go to the most common things, and check vitamin deficiencies and repeat labs. That's also a great parallel that Zaven said. Totally agree. And thank you, Austin. It was such a great case.
Thank you everyone for such a great discussion. It's as always a great case, and I'll just start by saying that we have a 58-year-old woman who presented to the ED with dysphagia, and we kind of started our schema with a dysphagia, and then Ricardo did a great job discussing and walking us through the importance of the age, the time course, and then because the time course would really change how our differential diagnosis. And then we also talked about the differentiating whether or not it's only solids versus liquid or both would be important in terms of forming our differential diagnosis. And then we also talked about the location of having dysphagia would be important to note because that would help us to see whether or not this would be more functional or just motility problem versus like an obstruction or anatomical problem. And then we kind of moved down when we heard that this patient is having more of a chronic progressive time course and then having weight loss, that we start thinking that we have to rule out with malignancy. And I would say, just summarizing the case briefly, that we have a very broad differential diagnosis, but some of the findings that really stuck out is her having glossitis, which presents in physical exam finding as a smooth and glossy tongue. And that could be due to nutrient deficiencies, especially with B vitamins and iron. And I think Zaven did a really great teaching point of thinking that we can't just stop at saying that this is a nutrient deficiency as a diagnosis. We have to see if there's any underlying cause and make sure that it's not some underlying cause that's causing this chronic nutrient deficiency, which in our patient's case, she has pernicious anemia. But then we also thought, okay, the anemia didn't quite resolve and the dysphagia was still there. So then we had to think about what fits the picture. And I think that we had a really good discussion about how the iron study didn't quite fit the picture. And because of our high suspicion for considering the whole clinical context, that it is important to repeat the study to make sure we're not missing it. And I think this is a great case showing nutrient deficiency along with a Plummer-Vinson syndrome with pretty much a very classic presentation of a DICE like dysphagia, iron deficiency anemia. They have higher risk of esophageal cancers and also esophageal webs, which we see in this patient. We also talked about some of the lab, and one of the teaching points I learned today would be if you have severe vitamin deficiencies, it could lead to like a pseudo microangiopathic picture with like a couple schistiocytes. And I think finally another teaching point would be that the B12 and iron deficiency commonly occur together. And when you have low HCl, that would decrease the iron absorption in your GI tract, which has also made me think about one teaching point I learned in boards is that that's the reason why you would not want to schedule your PPI with iron together. You would always want to separate them because the PPI would inhibit your HCl release, and that would decrease your iron absorption. That's it for today. Thank you so much for tuning in.
That was an amazing summary, Promise. Thank you, everybody. Hope you all have a wonderful day. See you soon.